Okay, good morning. It is April 10th, and this is Senate Health and Welfare. It's not quite as beautiful as it was yesterday or the day before, but it's still nice to have the temperature going. So this morning, we're looking at H 879 for the first time. The bill that came over to us regarding emergency temporary shelter program, the GA program, General Assistance Program, and that in the past has been very much a temporary program to help people through when there's housing needs, and this is a bill that came to us from the House with an update, and we'll hear from Representative Wood when she comes in. I thought it'd be helpful for Ledge Council to go through the bill with us the first time. So, there you go. Katie, thanks for being here.
No problem. Good morning, Katie McLinn, Office of Legislative Counsel. Let me pull up the document. There we go. So this is H 879, and this is the Emergency Temporary Shelter Program. Just to sort of take a step back and tell you what this is. As this committee knows well, every year when the GA emergency housing is discussed, the General Assembly makes decisions that are put in the budget and then in budget adjustment about what the program should look like for the coming year. In other words, the GA Emergency Assistance Program isn't a program that exists in statute. It is sort of a product of session law and the budgets and rulemaking. So this bill creates a shelter program that is intended to replace the GA emergency housing program, and it puts the parameters of the program in statute on an ongoing basis. Okay, so first is section 1, which is legislative intent. Would you like me to go through legislative intent, or?
Yeah, let's do that because it has implications for what the program is.
Okay, great. So it's the intent of the General Assembly that the Emergency Temporary Shelter Program that is established in a chapter that we'll be going over is a step towards ensuring that unsheltered homelessness be eliminated in Vermont and interim shelter opportunities be available to provide a stable pathway to permanent housing for all Vermonters experiencing homelessness. Arbitrary time limits, night-by-night shelter, relocation between interim housing sites and other disruptions in housing stability be eliminated. That non-congregate housing be used to the greatest extent possible. That Vermont's emergency housing statutes, rules, policies, and practices incorporate housing first principles, trauma-informed practices, and emerging best practices, including immediate access to shelter without housing readiness requirements, and voluntary supportive services designed to support housing stability, and that Vermont increases the supply of interim shelter that is geographically and physically accessible to individuals with a disability and that addresses the range of needs among individuals with a disability. So those are sort of the guiding principles or the legislative intent. And then we have the creation of the new chapter that was referenced up above in the previous section.
So Katie, now that we've been through the legislative intent, it might be appropriate then to put a stop here and then hear from Representative who has.
Perfect. I will pull this document down.
Great. It's actually good timing.
Good timing.
Legislative intent. Okay, and to let you know, I'm expecting my next person to be back in. We are all testifying in the House on this bill, so you're gonna see people going in
and out. Okay, yeah, I'm sure. And I brought my colleague, co-reporter, Representative McGill, with me.
Oh, terrific. Why don't you introduce yourself?
I am Representative McGill. I serve Addison 5, Weybridge, Bridgeport, Milbury, New Haven.
Terrific. Thanks for being here. And I am going to leave.
Yeah,
I'll be back. It shouldn't be long. And You're in good hands.
Okay. All
This is
right.
all orchestrated.
Yeah, apparently. So for the record, Representative Teresa Wood, from Waterbury, Chair of Housing and Services. And, thank you for having us today to talk about H 879, which sort of in the building has been named as the GA modernization bill. We have specifically, named it as a emergency temporary shelter program because it's not housing. We think of housing as being something that is a place where you live, where you create a home for you yourself and your family if you have one. And this is really an emergency temporary shelter program. You also might be interested to know, and maybe Katie has already said this, that there is little to no mention of GA housing as it's currently known in statute. And we've been spending over $50 million a year the last several years on this. And I always put it in quotes program because it's just really a financial benefit. It's not really a program as it stands now. And so our aim, and we've taken testimony from dozens of witnesses. The list was very long. And we heard from people with lived experiences. We heard from people who provide housing in the community. We heard from people who work within the Department for Children and Families who actually do the sort of on the ground work, the folks who interact with folks seeking assistance. And of course, we heard from leadership in the department and just advocates, legal aid, scores of different folks who have been involved with how this program, in quotes again, has run over the last several years. And I do want to say that what we see today and the needs that we see today are very different than what was known to us prior to COVID. And so that's an important thing to know. It's important to know that we don't feel like we can go back to pre-COVID times, where I will say that we probably had more people than we knew were homeless, probably not as many as we know today. Certainly the advent of the housing crisis has created the situation and has added to the situation that we have now because of evictions, because of people being sort of priced out of their places where they have lived. And that has exacerbated the situation that we had even during COVID, frankly. So we focused, we don't need to kind of like go through the bill with you because you'll have Katie do that, but we really focused our efforts in this bill at creating something that was predictable for people, creating something, and I don't only mean the people who access the service, I also mean the people who are trying to administer the program, because you'll hear from DCF, I'm sure, that they've had many iterations of a GA housing program, emergency housing program over the last several years. And in fact, in the last year, they've had to run like 3 simultaneous programs, which has caused confusion in the field. It's caused confusion for people who are homeless, for the hotels, for staff, for their contractors that they have employed. And for legislators, it's like, okay, we've got a cohort and then we have a non-cohort, and then we have off, or that's adverse weather conditions, this new way to say adverse weather off. So it has been a challenge. And so we were trying to respond to that challenge by being predictable in who's eligible and predictable for what the services are that somebody would be eligible for. What we also learned during this process is that, and I often refer to this as my food metaphor, that it's a giant bowl of spaghetti, okay? What exists out there now in terms of the community and in terms of what happens at DCF, whether it's in the Office of Economic Opportunity or if it's in the Division of Economic Services, is really all intertwined, confusing not only for recipients, but confusing for the people on the ground trying to administer the services. And So, you know, we have done our best to try to layer this up like a nice plate of lasagna, you know, to be able to have some order.
Turning spaghetti into lasagna.
That's what, yeah, that's what we're doing, we're, you know, it's
Pasta metaphor.
another constant metaphor, right? So, and what we learned is that it would be erroneous of us to impose a certain structure, an operating structure, without really additional work. And so you'll see at the end of this bill, the creation of a task force to work over the course of the next several months to come back to us with a recommendation about how this should actually be structured within the department, within the field, to make it more predictable for the people needing to access the program. And so, but what we felt that we could do is to create eligibility. That's okay. To be clear about who is eligible for the program, to be clear about what they are eligible for, to look at data in terms of making decisions about how much of a particular service that they're eligible for, and what we should be paying for that service, essentially. So we took into consideration the fact that we are encouraging the creation of more bona fide shelters. And there's between this year and next year, 180 new beds coming online for bona fide shelters that are already in the governor's budget. That was part of what has been budgeted for. But we do know that what is laid out in this bill is more than what the governor has proposed in his budget. He has proposed a flat 28 days, which is less than what is currently available to people. Today, they have an option between, depending upon the category, of 28 or 84 days, and then adverse weather conditions. And so you will see us try to simplify some of that here. We base this on the US Census Bureau occupancy rate, vacancy rate for apartment dwellings. And so we say, because we have heard continually that from the Department of Housing and Community Development, that the lower the vacancy rate, the higher we're going to have homelessness and the higher the cost for those rental units. That has proven to be absolutely true. I don't think that's, you know, rocket science for any of us. And so we set that rate at 5%. So when the vacancy rate is 5% and above, you would have access to a fewer number of days because it should be easier to find an apartment or a permanent dwelling. And when it's below 5%, we give you we allocate more days. And so the first is 45, the second is 90, recognizing that it will take longer time. And to be fair, we frankly don't think it's sufficient because it takes a lot longer. We know right now it takes a lot longer than 90 days, but we were also trying to live within what we felt was not spending more than what we're spending now, and needing to also find a revenue source to be able to pull this off. So, yeah.
Sorry, go ahead. There's no chair or vice chair. I'm chair. Thank you.
Yeah.
I didn't know who that. Yeah, me too. Go ahead, Senator.
Senator Coolidge.
Thank you very much. There you go. Thank you very much. So yeah, so I'm just hearing those days and it just seems very not inappropriate, but just not sufficient to I understand the amount of time it might take to find a house or a place to live, but what about someone who's got these extenuating life circumstances, like loses a job, doesn't have a car for a certain period, like, are those taken into consideration when thinking about the amount of time that one will get to stay in a shelter? Or did you really just use that metric of like finding an apartment, finding a place to live?
Well, in terms of what we put in the bill, it's that census data in terms of vacancy rate. we would expect that there would be, like there is now, rules that are developed. Right now, there's a point system in place that enables you, you know, they look at different circumstances and that sort of elevates your status. if you
Great,
will. So,
that was my question.
Yeah.
Good to know that at least there'll be some more structure put in place.
yeah, well, and that's part of what we want to see come out of this working group, you know, so the other things that should be considered in actually operationalizing what we've put forth here. So, and then we do continue adverse weather conditions. We do not do this hybrid thing that causes great confusion in the field right now, where you know, when you first enter, it's weather dependent upon whether, you know, in your part of the state, it is 32 degrees or whatever the cutoff is, or there's rain expected or whatever. And then on this end, which we're still in right now until April 15th, again, it's that hybrid. And in between, you know, it's access for anybody who's homeless. So we said the hybrid thing just is very confusing in the field. It's very confusing for participants. It's confusing for hotels. It's not good for staff. You could have somebody being eligible in the Northeast Kingdom because it might be a degree or two colder, but in, you know, central Vermont, they wouldn't be eligible. And so it's a nightmare to manage, frankly. So we just set the dates as you know, we set them in statute. We also set a process that the legislature would approve the amount that is paid to hotels on a daily basis through the appropriations process. So that is something that we would essentially control here based upon recommendation from the administration. And then I do need to point out that two things. One, that this is tied to the housing/revenue bill, 829. You'll see on the fiscal note for 829, and I don't know, that probably won't come to this committee, but it's something for you to know that on the fiscal note for 829, there is $40.7 million on the bottom line. Okay, that is essentially unallocated. It's not allocated in that bill because it is allocated to this bill. This bill in the structure that it is doesn't exist without that additional revenue. So I just want to be open and clear and transparent about that.
So I have the two, thank you, two fiscal notes. So there's on each 879, these are the same number?
Yes.
Okay,
Yes.
okay.
And the second, yep, go ahead.
And just to point, you know, those working in conjunction is, I read through the fiscal note for H29, you know, in the first, it's like a phase plan. And so in the first couple of years, a lot of that funding will go towards building up emergency shelters. So folks, you know, if they're not able, they max out their time, you know, in a hotel, there's more opportunities to move into shelter. And then over time, you know, we are building less shelter, but more affordable housing, whereas it kind of switched in the beginning. And then I think, you know, the focus on these kind of new shelters we're building, like the motel conversions and non-congregate shelter. I think as we have hopefully like an overall less of a need for emergency shelter long-term, those kind of buildings, those work great for permanent supportive housing. So they can be, there's a lot of room for transition based on the needs of the state.
Yeah, and we did hear from VHCB that that's a focus for them, is to, you know, when there's a hotel conversion, that they have one that they're in the process of doing right now. That they're focusing on something that, yes, it'll be a shelter for right now, but it will be fairly easily convertible to permanent housing, permanent supportive housing. And the data shows us that while we still do have a number of children and families who are homeless, the biggest need is for single occupancy housing. So those hotel conversions are easily converted to single occupancy housing. So that's one piece. The second piece I want to be absolutely transparent about is the budget bill, H883. When we were developing this transition year, because this program, as it set out, would not be implemented until FY 26, so January 1, 2025. And we allow that year because of this task force that'll be working, and we're able to come back next session and lay out sort of the second piece of this, which will be the operational piece. So we needed a transition year. And during the budget development process in the House, in conversation with the Sheila Livingston, person who you know you're well, she requested that we actually not have too many transitions. So that what they have right now, then something for 25, and then something yet again for 26. So she requested that we take the language, the eligibility and the service language, and put it into the budget for this year. And so I want to be clear that that's, traveling parallel to this bill. Of course, the chair sits on both committees, but it's important to know that there are budget negotiations happening in 883 at the same time that you're considering 879. And we need to make sure that at some point in time, those things match, or that there's some sort of transition process. For those who might be aware, the Department for Children and Families appeared before Senate Appropriations with a dollar figure that was in excess of what they had told the House it would cost. We are working with them to refine those numbers. We already know that they were too high because they were making certain assumptions that were actually not accurate. And we've been clear that we do not want to hire a bunch of state staff at this point in time, because the program, the operational part of this is yet to be defined. So we don't know what it is that we're going to need yet. And so we have indicated a preference for them to continue with contractual services and temp employees at this point in time to continue to operationalize this. Other points you want to add?
About the advisory group as well?
Yeah.
So you'll also see early on, after once the chapter is established, it creates an advisory group of folks with lived experience. Kind of each lead agency of continuum of care around the state would appoint someone. And they will serve as an advisory committee to the department, the commissioner, and they'll have 2 members who are also on that task force. We've just learned a lot in our committee, getting testimony from lived experience experts, that a lot of times when they're just on these task force, and it feels like they're just kind of a token, and it can be hard to have these conversations. And so this was just something where they can kind of have an affinity group to talk things over. We'll get a wide perspective of, experiences throughout the state. And then they'll be able to advise the department, especially through these transitions and, whatever hiccups may pop up along the way. So that's something you'll see. That's the advisory committee.
Okay,
versus
there's an
the task
advisory
force.
committee and a task force.
Yes.
Okay.
The advisory committee is permanent. I mean, we sunset it because our GovOps committee wants us to take a look every some period of time. Yes, those GovOps people,
Okay,
The other thing I just mentioned, is one thing we heard loud and clear from multiple entities is the definition of disability is insufficient. And so I want to be clear about where the definition of disability comes from. We didn't just make it up off the top of our heads. It comes from the HUD definition of disability. It is exactly the HUD definition with one exception. HUD identifies age 65 and we identify in this bill age 60. And the reason it's age 60 is because that's consistent with the Older Americans Act, identification of an older Vermonter or older American. That was something that was clear from the outset needed to be addressed. And it would also potentially do away with the need. I know there's been a lot of confusion around the disability verification form and a lot of consternation back and forth about that. And we are hopeful that being clear about what disability means would lessen the need for any kind of like, ongoing need for some sort of
Right.
verification form. So that was a big deal.
Okay, I'm gonna stop you right here and, so Senator, I've been chairing while nobody else, while you and Ginny are out of the room, but, we are at time with this. We haven't walked through the bill, so either we can walk through the bill with Katie or we can move on to the next bill. So,
Okay,
Um,
so,
this is 879, the temporary shelter, and the next one is the Medicaid bill. So, what is your preference?
so,
I think we're finished with the,
you're done.
I think that we are done, yes.
yeah. Did you have a quick question
Just
for
a,
them,
just a
Senator?
comment,
Yeah.
in your advisory group when you're doing it, I look at things from 30,000 feet, and I've been involved in my
You know,
district,
yeah.
so. If we take all the money we've spent on housing, temporary housing and, homeless prevention, committees, and put all those man hours in, sometimes I think that, we didn't see this coming, but we should have, because I think it was predictable. And then COVID really exacerbated it, but when you talk about the advisory committee, we need to build some space into it, because it's gonna happen again.
Yes, yeah.
And that way, maybe we've been better off have some entity go buy a chunk of land and build some transitional housing. For all.
Exactly, and all of those things are contained in 829 to be fair.
Yeah.
And the other thing that I wanna say is that you're exactly right, and this is only a piece of the puzzle, so we're working on recovery housing in the budget, you'll see, there's elements of multiple types of housing that will address this, so. And the department was very clear with us just recently, just after we passed this bill, that they need to improve communication. They've been very open about the fact that communication has suffered. And this advisory committee will help them to formulate things in plain language, things that will be understandable to individuals, and they've never had that. And so,
Just Rutland City alone had 3 different groups working. And I started finding out, getting invited to meetings. I let Chair Lyons know that I was doing it, and she said, "Who's in charge?"
that's the
No.
bowl of spaghetti I was talking about. That, we have to do something different.
So we need to build a structure whereby the next
Exactly.
time it happens.
Exactly.
Yeah, no, that's okay. While we're transitioning, I thank you both very much,
Yes, thanks for
for
your-
your, presentation. We're gonna, I think, move on. So we've just gotten through their presentation. Katie has not walked through the bill, and now we're at 766. I misspoke. It's the prior off bill. So I don't know what you wanna do, Madam Chair, but I'll turn it back over to you.
Oh, good, you put me in the hot seat. No, that's terrific. Thank you, Senator. So I think we will move on, and Katie, we will come back. Katie's on Zoom today and has some personal issues, so this is probably helpful to move on to 766 and hear from folks who were going to offer additional testimony on the prior off bill.
Perfect, thank you.
Yeah. Okay, so we have Kristen Connolly. You're here. Thank you for being here.
I'll be right back.
Good morning.
Good morning, thank you.
Now, we need to get, our brains were just in housing. And so now they're transitioning to prior authorization, the health insurance claims, codes, contracts, all those things. Now, I think we're back.
All right.
This is good. And so thank you for being here.
Thank you.
We're going to introduce ourselves.
Good morning, I'm Senator Florentine LaRock Ulick. I live in Burlington and represent Chittenden Central. Nice to see you.
Good morning, Dave Weeks from Proctor and I represent Bucking County.
Jenny Lyons, Chittenden Southeast.
Terry Williams also from Rutland County.
And Senator Hardy is from Addison County.
Perfect. Well, I'm Dr. Kristen Connolly, Longshin, is that okay for
Yeah.
everyone? I'm a pediatrician at Timberlane Pediatrics and a member of the American Academy of Pediatrics Vermont Chapter Board and Vermont Medical Society. Timberlane Pediatrics, where I work as part of Primary Care Health Partners, which includes several pediatric and adult primary care practices in Vermont. Our pediatric practice cares for over 8,000 children, with patients in 3 offices, Burlington, South Burlington, and Milton, where I work. And I serve in the Milton office patients from Franklin, Grand Isle, Lamoille, and Chittenden counties and beyond. And I thank you to the Senate Health and Welfare Committee for the opportunity to talk today and voice my support for H 766. I'd also like to thank the Vermont House of Representatives and Chair Hogan for their work on Act H 766 unanimous votes in favor, and urge this committee and the Senate to support it fully. I'm here before you today because in more than a decade of serving as a primary care pediatrician in Vermont, barriers created by insurers have been one of the greatest obstacles to providing patient care. Insurance required prior authorizations delay or block access to important treatments for patients, require significant time to address that diverts from direct patient care, and add remarkable and unnecessary expense to an already too expensive healthcare system. Insurers frequently change their their preferred formulary medication list, and it often does not reflect best clinical practice. And this is exasperating for both healthcare providers and is particularly challenging for patients on long-term medications for chronic conditions. One of the most egregious examples of this was the insurance coverage change for asthma medications in January 1st of this year. Asthma is the most common chronic condition of childhood, and in January, at the height of the respiratory virus season on the tails of a global pandemic driven by COVID, insurers changed their preferred medication formulary for asthma entirely. They removed coverage of the most commonly prescribed steroid medication inhaler for those with persistent asthma, even though it had become available as a generic medication. And the only other similar steroid inhaler that could be administered with a spacer, as is needed for infants and young children, has experienced substantial drug shortages and has been mostly unavailable. Children, physically and developmentally, infants and young children cannot be coached or physically execute breath-activated inhalers, but the insurer has only offered those as alternatives. And as healthcare clinicians, we use step-up therapy to guide best practice for asthma medication management, but we've been left without any age-appropriate options at all. And families who've seen their children hospitalized with asthma exacerbations have been frantic, as have we, trying to track down medications and approvals before another illness hits a vulnerable child with asthma. And I always ask myself, how can you deny a medication that enables a child to breathe? This is a direct safety issue that we in pediatrics are navigating daily right at this moment. Massive changes in preferred formulary medications for ADHD are also ongoing, and children with ADHD who've had social, academic, or other struggles improved after starting ADHD medication have been overwhelmed when insurers decide not to cover that medication anymore, arbitrarily often. This has been further complicated by medication shortages and added significant stress for patients and families. And these decisions have decreased access to medication that have further exacerbated the mental health crisis that we are navigating daily, primary care. Children with complex healthcare needs, whose families are already under significant stress, have often had to repeat the same prior authorization process for life-sustaining medications that they've been on for years. I once spent hours on the phone with an insurance company trying to advocate for a young infant who is malnourished because his gastrointestinal tract could not digest proteins in regular formula. And he needed hydrolyzed formula, which is where the formula has the proteins more broken down for easier digestion. But I was told this could only be approved if this baby had a very specific metabolic condition or a gastrostomy feeding tube. And this decision had nothing to do with good medical care, but with cost savings. And it took hours of writing letters, phone calls, and signed prior authorization paperwork before they approved this needed formula, and we were finally able to see this young infant gain weight. And again, no family should ever be waiting on an insurance company to be able to feed their starving baby. I was once on the receiving end of these challenges as a patient myself, as I imagine many of you have been, through 3 pregnancies complicated by chronic severe nausea and vomiting. And each time when my obstetrician prescribed generic anti-nausea medication to enable me to continue working as a pediatrician, and avoid hospitalization due to dehydration, I had to spend hours on the phone repeating the same conversation and the same process over several days of being violently ill before the prescription was approved. And it astounded me that my insurer would rather risk me being hospitalized and losing a pediatrician from the workforce than approve a generic medication. These unnecessary prior authorizations and frequently changing medication formularies are not motivated by improving patient care or by reducing patient cost. In fact, many are not even consistent with clinical guidelines. The effects on patients and risk to patient health are tremendous. The added burnout to an already thin primary care workforce is significant. The challenges with staffing that every primary care office in Vermont is facing right now is made more difficult when dealing with prior authorizations becomes someone's full-time job instead of providing direct patient care. When I find myself on the phone trying to explain why a medication is needed to feed a child, to help them breathe, and to help support their mental and behavioral health and access to their education, I wonder who would ever think this needed an explanation. And I wish I could just show the other person on the end of the line a photo of the child that they're denying care to see if they would reconsider. I urge the Senate committee to support this very important bill, which will require insurance companies to approve prior authorization requests quickly and allow someone to stay on medication they're stable on without a new prior authorization or going back through step therapy, and bring it to the Senate for a vote as soon as possible. And I thank you for the opportunity to speak before you all.
Thank you very much. Do we have your testimony on?
I have a copy of it.
Okay, can you send it electronically?
Yeah.
Okay, that'd be good. Yeah, that's terrific.
Yeah.
Appreciate it very much. Questions? Thank you for your work.
Can I ask a question? I think I already know the answer, but when you're talking to insurance companies, the person you're talking to, are they a physician?
No, in fact, with asthma, we have been denied the ability to have any doc-to-doc calls, which I've requested over and over again. We've been in this crisis. We're now in April. We've had unnecessary hospitalizations, which, as we all know, cost far more than a generic asthma medication. And right now we're being denied the ability. So no, usually they put a very kind person on the phone to help kind of deal with all the bureaucracy, kind of the logistics, and try and lead us through a whole network. But we literally have nurses whose full-time jobs right now are to navigate this instead of doing work as nurses, taking care of patients. And
So
it's
the insurance companies themselves are paying poor people. So what a terrible job to tell a doctor, no, I'm not gonna approve the thing that you think is the best treatment for your patient. And they're paying somebody to do that. And then they're
Astronomical.
saying
Yeah.
that the bill is gonna cost them money when they literally could save money by not having these people on their staff.
The amount of resources put into these blockades is astounding. It is an unbelievable waste of resources. And no, they are not doctors who are telling doctors that they should be prescribing clinically evidence-based medicines. They are these rules.
And they're certainly not doctors in the same specialty. You don't hear from a pediatric allergist. Where in Timber Lane, there are pediatric allergists. Hello.
The pulmonologists and allergists are dealing with the same struggles right now.
Yeah, and meanwhile, there's a waiting list to get in to see pediatricians for a lot of the areas.
I actually have had several conversations where the kind people on the other end of the phone who are being paid to field these calls thank me for advocating.
Oh.
Because I think they know.
They probably have a child with the same problem.
Yeah.
So,
Thank you.
But yeah, thank you, I appreciate it. I'm very happy this bill is before everyone right now because it's all.
Soon, we're hoping it won't be before us, it'll be out.
Yeah.
All right, so, and Rick Dooley is here, physician assistant. Thank you for being here.
Thank you for having me.
It's a great center, Thomas Chickton. Now where it is, it's near home.
Excellent, excellent. And I just want to echo some of Dr. Conley said, when she said she spends hours on the phone, that's not hyperbole. It's, all of us have done the same thing, literally spend hours on the phone talking to someone for prior authorizations for a single medication and then on to the next one. So I'd like to thank the Senate Health and Welfare Committee for this opportunity to address you about Bill H-66. I'm Rick Dooley. I'm a full-time family practice PA at Thomas Jennings Health Center in Williston. In addition, I'm also the Clinical Network Director for Health First, which is an independent practice association representing independent specialty and primary care practice across the state. So I have sort of a more myopic view of Thomas Jennings, but also I've heard the same things from my colleagues in independent practices across the state. I'd like to tell you a little bit about my practice in Williston, which is right down the street from Ginny. We're a family practice serving approximately 13,000 patients. We have a full service clinic with 12 FTE primary care providers. We have a nutritionist, a social worker, 2 part-time psychiatry nurse practitioners, and 3 part-time care coordinators, and a full slate of clinical and non-clinical staff. We have, in fact, about 3 staff people for every 1 primary care provider. Some of our other Health First practices have as much as 4 staff people for every single primary care provider. The need for the expansive staff is twofold. One is because it requires a significant investment in clinical staff to provide the growing number of services, both medical and social, that are falling on primary care. It's not just cough and colds, there's a lot of stuff falling to us now. And second is just the administrative requirements around billing, payment processing, insurance requirements, prior authorizations, audits, and reporting are all onerous and time consuming and requiring us to employ more and more people to do these jobs. The burden of prior authorizations for medications is crushing. At the start of every year, we begin the annual slog of expired PAs, as Dr. Trump was mentioning, where patients who have been on medications for the past 12 months are now no longer considered formulary. Hours and hours of staff and provider time is spent daily over the first 2 months, completing online forms, combing through charts to provide dates for previous trials and failures, and writing out justification of why medication should continue to be covered. It's not unusual for a nurse or MA to spend 45 minutes to an hour on hold just to speak to someone to get a single prior authorization. My nurse spends probably an average of 2 to 3 hours every day working on prior auths in between rooming patients and taking calls. The patients often react differently to different medications, even within the same class. So change in medication because of a formulary requires close follow-up. Sometimes the formulary changes an entire class and changes the result of an entire class of medication being excluded, resulting in a need for a trial of a medication that I may not feel is appropriate for the patient. Dr. Fowler spoke of that session, but I would just say the same thing happens with antihypertensive, anti-diabetic meds, certainly inhalers for adults. We have the same thing, where classes of medication are considered excluded.
Madam Chair, can I ask a question? It's up to you.
Those
If you
are-
mind doing that.
Absolutely.
It sounds like the prior auths that are causing you the most headache are for medications. Is that true, or are there also?
Oh, there are others too. Okay.
Because both of you have talked mostly about medications, and that's true. Okay.
It's easier to understand.
Absolutely. I think medications, all of us have had medications that have been denied or been changed because of it. And I think the medications are a huge issue, but the others are as well. With regard to step therapy, so step therapy is sort of, prior auth, the subset where you are required to try one drug before another. With regard to step therapy, the provisions in this bill we strongly support. The decision to use a specific medication is not made lightly. We as providers are often balancing not only the mechanism of action, but also side effects, interaction with other medications, the ability of the patient to maintain the dosing schedule, etc. I've been in medicine for 30 years this year, and the difference between drugs, even within the same class, is astounding. So I'm going to use just an example of this, and then it's still medication. I'll get the other.
Okay.
An example of this is the SSRI class of medications, so serotonin drugs that are commonly used for depression and anxiety. There's several. Everyone's heard of Prozac, Paxil, Zoloft. These very common medications to use. And I've been using them really since their inception. The insurers will have you believe that they're all just interchangeable. You can take Prozac, you can take Zoloft, you can take Paxil, they're all the same thing. The reality is they're actually very different drugs. So Prozac, for example, has a very long half-life, meaning it stays in the system for up to 5 weeks. It takes a long time to build up, but once it's there for a long time. So if I have someone who's not terribly compliant and who maybe will skip a day or two, Prozac's a great drug because if they miss a day or two, they don't notice the difference. Lexapro, Restelgram, has a very short half-life, so it gets there quicker, but if you miss a dose, you notice it. So I may not use that for someone who may be, who I'm worried about missing a dose, but I may use it for someone who needs a quicker response. Paxil, exact same class, tends to be more sedating. If I have someone who's very anxious or having trouble sleeping, Paxil is a great drug to use for that. If I have someone who's fatigued, I don't want to use Paxil. But the way the step formulary reads, I may have to use Paxil before I can use any other medications, regardless of the patient's other symptoms. With regard to prior authorizations for imaging or treatments, we spoke about, there are various points of frustration. One is around the timelines around approvals. So oftentimes, imaging or treatment facilities won't schedule an appointment until the prior authorization is approved. The scheduling staff will work diligently to get the approval, but the approval is only for a set time period and for a specific facility. So say it's good for 30 days at UVMMC. By the time we go to schedule the appointment, we can't get an appointment within that time period, or we can get an appointment at that particular facility. And then we have to go back in and get the appointment, try to, when we go back in and do another prior auth, modify it, and then play that game over and over. The patient comes in and says, oh, good news, I found out that, Rutland Regional can do my MRI quicker. We have to go do another prior authorization so they can go to MRI at Rutland. It's a ridiculous system. And we have literally 2-3 full-time schedulers whose job is just continuously do these prior authorizations for imaging. One more just sort of ridiculous that came across my desk a couple weeks ago. I have a patient who is on a CPAP machine, has been on the CPAP machine for sleep apnea for years. And she needed to recertify. She has had a number of issues in the last few months and hasn't been able to use her CPAP machine consistently. So the insurer said, well, we need a prior authorization to say that you actually need a CPAP, and we see you haven't been using it appropriately or using it consistently. And she said, well, I've had these things. So while your doctor needs to certify that you haven't been using your CPAP. Now, I'm not in the room with the patient at night. I don't know if she's using her CPAP or not. I don't know why, but I know I am. So they say you need to do a prior authorization. I said, fine, we get the paperwork and sent it in. Well, you need to do a peer-to-peer. You need to speak with the provider about this. I said, this is a ridiculous thing because I'm not going to say anything different than the patient is telling you. But I said, okay, here's, I can do the prior auth, and I call for the peer-to-peer. They don't know, we need to schedule it. It's like the cable guy who comes sometime between 8 and 12. They said, we need to know, what hour you'll be available next week, and we'll call you sometime within that hour. Now, this is for a prior authorization that I don't even think is necessary. I don't want to do it, but now I have to set aside an hour of patient time or do it on my own time and set aside and wait for the phone call. So
If I could, I just want to make sure I understand the concept. So peer-to-peer, are you talking to peer at the insurance company?
peer at the insurance company, which is not necessarily a physician or oftentimes it's a clinical nurse of some sort.
Okay, I just want to make sure.
Yeah. My last point with prior authorizations is that almost all the time, my prior authorizations are approved. So if I order a medication, generally it's because it's the right medication, and I jump through the hoops and spend the time on the phone, and then it gets approved. If I'm ordering an imaging study, it's because it's the most appropriate imaging study. No one orders them just willy-nilly because we want to. There's no benefit to that to us or to the patient. If I'm unsure about the appropriateness of a study, I speak to radiology before I order it, and we go with best practice. The issue is not that they're not necessarily getting approved after time. It's that we're dedicating tremendous amounts of staff and provider time to comb through charts, complete forms, schedule these reviews, and write letters, just to get a service that we all know is medically appropriate. In essence, prior authorization is just a roadblock to patients getting their needed care and can only be circumvented by primary care providers and staff investing their own unreimbursed time and resources to do so. Prior auth and medication step therapy are not the only source of administrative burden. I know that, and I harbor no illusion that H766 will eliminate all of our primary care woes we're facing. But I truly believe we need a strong foundation in primary care to improve patient outcomes and reduce system costs. We can't provide that foundation if we don't have providers who are willing to join primary care. Administrative burdens are a huge reason why they won't join us, and we need to do everything we can to reduce it. Bill H766 takes a step in that direction. Thank you.
Thank you.
Thank you. Thanks for your testimony. My question is around other testimony that we've heard that suggests that, if without prior authorization, there will be, some, abuse of the system, corruption, graft, all these things. And
Overutilization.
right. And I'm just wondering what you or Dr. Connolly would say to that, if that's something that you.
I mean, I would say
Let you answer.
I would say that's silliness. And the reason is because patients don't want to take 1,000 different medications. There are still co-pays and costs associated with medication. Patients don't want to take extra meds they don't need to. patients don't want to be imaged every other week. You know, and I don't think, I think you have to have faith in providers. The presumption that providers are somehow out to game the system, in Vermont, there are probably parts of the world where that does happen. In my provider colleagues that I know, I just don't see that as an incentive. I don't see, unless there is, I mean, there are, Star Plus preventing that. I can't call one open MRI and say, good news, I'm gonna send you 16 MRIs a week and you're gonna kick back $1,000 a week. You can't do that, like that's illegal anyway, so we don't need prior authorizations for that.
I would echo that, we take a Hippocratic oath, first do no harm. Like, I would not be a pediatrician if my number one priority wasn't taking care of patients. And the decisions we make are evidence-based, after 4 years of medical school, 3 years of residency, and years in practice. There's no Hippocratic oath for insurers. There's, when they say that someone's going to game the system, it is very clear that the gaming of the system is not coming from the clinicians. And I think that there's not enough regulation happening on that end, and a lot of our healthcare dollars are wasted because of an inefficient system with them having free rein.
Thank you for that comment. We identified the lack of regulation at our last meeting.
The other thing I'd say, when they talk about their costs, they say, oh, it'll be expensive to them, but the reason it's not expensive to them now is because all the cost is on us. It's our staff people who are making the calls through the prior auths. It's our time that we're spending on the phone. Any hour that Dr. Conway are on the phone is an hour time that we're not seeing patients. It's coming out of our pockets, not theirs.
But we do it because it's important.
No one's on the primary care coverage.
No.
That's
Thank you. This is extremely helpful. Probably our next steps on the bill will be, next time we schedule it, will be a more discreet walkthrough and try and look and see if there are any places that need some change or improvement. But we're close now to markup and moving the bill along, so appreciate your time.
Thank you.
And if you could send your comments into Kiki, both of you, then we'll have them on our book page. Okay.
Thank you so much for that.
Thank you.
Okay, so. All right, so yesterday we took a quick look at funding issues in here in budget. We call it budget, but it's really some of our concerns and wanting to make sure that things are considered during the budget process. And Amy, you've put together a terrific list for us. But if you can come up, if you have it online and Kiki, I think it makes, yeah, that's what I was just gonna say, let's hand it out. There. And I noticed there are at least one or two things here that don't belong to us, but that's because you don't know what belongs to us. We get.
Did you want, so Amy Pope from Joint Fiscal Office.
Thank you.
Did you want me to share it on screen?
Sure, let's do that.
Try.
And just as I said, for example, we don't do Vermont State University based funding.
Sorry about
That we can come up. No, I didn't, no, you didn't know that. That's okay. And I know you had a much longer list to sort of get down.
So apologies, this is.
And I should share with the committee where this comes from. The Appropriations Committee had 2 public hearings a while ago. And during the public, we asked for folks to come in with their budget requests. And so it was a much longer list. Many of the requests that were on that list are in bills or in the budget. And so Amy, you can present that as we go forward, but I just want folks to know that this comes from a pretty broad public hearing on budget requests, and Amy, you've done a great job of getting it down to the areas that affect us.
Thank you for your patience here as I.
Another beautiful brooch.
Oh, thank you. Try to add a little joy to the day, right?
Yesterday, you're matching with the
I
class was
know, I
really,
did, I
perfect.
did.
So was that
Pretty impressed.
Eclipse inspired?
My husband purchased this for me a few weeks ago, so it's just sort of.
So it is.
I did notice.
It is Eclipse inspired.
It is, yes.
Oh, look, there's some.
Yeah.
Um,
Get a little bigger.
Yeah, that's a good idea.
How's everything looking up there?
Better.
Okay,
It's good, yeah.
let's do what?
We have it in front of us, so we can go back and forth.
Okay, so what I have done is sort of captured everything that I think I heard over the two public meetings that we had on the 13th and the 20th of February. I also tried to find different bills that I think the requests may be found in, so you'll see that on the right-hand side. And if you want to go into detail about this specific request, at the bottom of the page is a link to the Senate Appropriations page where you can see all the requests. There's several hundreds of them, so you can find out more about each request there. Sometimes there were multiple people identified the same amount of money for the same program, and sometimes it was just one individual. So do you want me to just sort of go down? Or
Why
do you
don't,
wanna-
I think what would be helpful to us is for you to go through briefly as those things that are not currently in a bill or from your understanding, are not currently in the budget. And that, so we know what is now is in the budget as it came from the House and being discussed in the big bill and then down the hall. And then there are things that are not there. Those are the things I think we need to highlight, the things that are not.
That sounds good. So I organized it by cost. So the higher costs are at the top. It has nothing to do with priority or anything like that, just primarily the amount that was requested. So the first item is universal paid family leave. That's an initiative that folks may have heard over the past several years. Update the formula to meet the REACH Act statutory obligation, and that there is a report that comes out each year by the administration that identifies what that difference would be. And 6.5% Medicaid increase. I don't think that that's in the base. I'm not sure. So that's $14.6 million. Then there's a long-term care crisis, choices for care, and enhanced residential care rate study. There must have been a study that identified this amount, and I did not have time to determine if it was in the budget or not, but I'm assuming not, but I'm not sure.
I don't think so.
And then the next two items I think are the same request, but there was a report and an Act 186 that identified housing for a development disability. That is not in the budget. And
There
then-
is some language in the budget regarding housing through the VHCB, a specified amount through VHCB for sort of higher to lower level, not that they're all higher to lower level requests for housing. And yesterday I asked to have for us to consider language that would include disability housing. So some of that is being discussed. I don't know the amount that this lower than this, but there's a specified amount through the VHCB that's there. So we should know that. Okay.
The next piece is sort of you can think of it as justice investments. And H880 identifies, H880 has quite a bit of these requests in it. And that's now over here in the Senate. The food bank, 5 million, that was a request for a base appropriation. And then you identified that Vermont State University is not part of yours.
We can cross that one out.
Meals on Wheels, this is sort of an idea of taking money that's already appropriated in Dale, I believe, and then kind of grossing it up with general, with GC, so that's in the budget in HAB.
Yeah, and I think that's well supported in the budget.
An increase for federal qualified health centers is not. So an increase over what's in the base is not in the budget.
So this is the base, yeah.
Serve, Learn and Earn, is in H83, the House proposed.
What is that?
So it's a program,
BYCC,
Oh, it's the Vermont
Vermont Youth Conservation
Corps.
but
this isn't really ours either.
Okay.
This is probably not ours. either.
more of a workforce.
Yeah, it
Okay.
is, so unfortunately, but we'll just, I think we have to cross that out. This is somebody else's vote. But it's in there.
It is in the House as passed, yes.
Okay.
Adult Day, increase, so, you know, the base funding from last year is into the budget, but not an increase to the providers. The LAOB, is in H829. I think it must be at $1 million, but
And for what's LAOV stand for?
land access opportunity. Thank you, opportunity board.
Yeah, that's also not really.
This is really not ours either, so we can cross that one out. I mean, it helps if we don't have to consider somebody, these things are.
There is 1.65 million requested for an increase to the LUPA rate, and that is in H83 at 1.6.
This is the choices for care.
ENAs.
And yeah,
ENAs.
so that's in the budget.
That is in the House's proposed at 1.2.
Yeah. Okay.
Let's increase in base financial recovery residences. Yeah, is that through the opioid settlement money? Yeah, so I missed that, so it looks like that.
Oh, so that's an opioid settlement statement. So that would be included.
It would be,
Yes.
H83,
Right?
peer recovery in corrections, which I think might be in this larger justice reinvestment.
Yeah, and that's kind of ours and kind of not ours, so we probably can cross that one out. And I know that that's a discussion in appropriations.
Is it also potentially a discussion in the opioid side? Is that not?
Oh.
I think it's justice reinvestment. All of you,
I don't know.
no, so.
I don't know.
We'll just, I can't answer your question.
DOC landlord tenant laws and certified residents expanded from the opioid settlement fund based increase.
Okay,
They don't have real estate, done for justice abuse.
Right,
Yeah, that's.
yes,
same with the next one, right? The landlord tenant.
Amy's credit, we said human services, and so DOC is part of EHS, so.
No, it's tough.
And also to Amy's credit, this was an internal sheet that she tried to convert to public sheet very quickly.
did my best. EMS training.
So there is a bill, 310, that includes 150,000, and then there's a House bill that includes 300,000, which I think is on your wall, Chinny.
Which line item are we on?
EMS training.
622.
Yeah.
622.
That might be 622.
It is 622.
Yeah,
So there's,
well, if
it's
we,
not $1 million, but it's some money for those
Some-
things.
And I did review that and I wasn't sure if it was the same.
so,
But it's
you know, when we have a
there.
bill, like we have bills in here that will connect with some of this funding. We'll be passing those bills out. And that will demonstrate support. Okay. What line are we on?
We are at
Are we on?
Meals on Wheels, which I think I already identified
Yes,
above. The PAGS access is not yours.
no,
Transitional housing for refugees. That's probably a housing.
it is a housing thing. And it's in 829, which is not here. But we will weigh in on that bill for types of housing. Let's just hold that one for now. Decide how to deal with it.
So we're at salaries and administration at the parent-child centers was a request, but it's not. Was not in the governor's recommended, it was not in the House as passed. PDH tobacco control use cessation education. I didn't have time to research that. Or item for parent-child center, and really it was two different requests and two different amounts, so that's why I put it in there twice. The Spectrum Youth and Family is in H83 as a one-time.
That's already in the big bill.
Yeah.
And starts a new program in St. Albans, I think.
First, I think like the health centers, Medicaid equitable rates in DIVA. Early childhood local school, that
Is
one,
that the same as the FQHC request?
I don't know.
So it might be. Related. No, okay. All right, keep going.
I think the early childhood local school, I don't, that's
Okay,
another one I'm not
Yeah.
sure about. Dementia respite. There is a small base appropriation in AHS. There was no increase on the House of GovRec. Let's see, opioid settlement advisory committee for recovered rent and scholarships.
That's in the budget.
that's in the budget.
And post permanency is also in-house proposed.
What does that mean?
That is,
I know it's in the budget. Do you want to comment on that? You're here, so say your name for the record.
My name is Christy Leonard Raker. I'm from Easter Seals. And yes, this was a request that came through appropriations and it is for base funding, $300,000 post-permanency programs serving statewide in partnership with London NFI. Children who have predominantly been adopted through the state's foster care system and providing that support as a stabilization effort. We've been level funded for 12 years. So we're looking to stabilize the program.
So this is the NFI Lund Easter Seals.
Correct. We have a state contract.
And can you share very briefly what post permanency does, what the program does?
So we have staff who are in homes, working actively with families on everything from normative adoption issues to the more specific issues that children face when having experienced early trauma. Those things do not go away once the kiddo finds permanency. And we are there trying to help stabilize families so that those connections can last. And so that they're not coming back to DCF.
Right, so these are families who are not within the custody of DCF.
Correct.
May have come out of Lund. And so you're providing them the continuation of support that they might have received.
Correct.
In, so, okay, thank you. That's helpful. Okay,
so I have two more items that have had actual dollar figures associated with it. It's the SFA pilot program, Sash Model Community Health Approach to Homelessness. And just looking at my notes.
was that a program that we started last year, pilot? And then it's continuing, or is this the new pilot?
Is this something that might be in one of the housing bills too?
Okay, we'll have to sort that one out. We'll look up on the page. We'll look out on JF.
Yeah, yeah.
This is our first shot.
And then the final number for peer support for families that have lost a baby is the MTR of 40,000. That's also not in the budget. So the animal welfare should not have been on the list. And then the other items are sort of notes of
Medicaid reimbursement rates.
So empty arms, we should stop there because I don't think we take any testimony on that here. Is a program that supports people who may have lost a child early at birth or afterwards and provides family support. It's also statewide. I might have to say your name.
Sure, Chelsea Levis with FD Arms Vermont. It is statewide. It's the only statewide program. And just to be clear, this request would be under the jurisdiction of the Family and Health Services Division, and it's a one-time budget request.
And why is it one time?
What we'd like to do is continue to develop for sustainability, and we don't want to come back to the state every year, but we could use funding to go from an all-volunteer team that's supporting over 100 individuals to really building out our organization in partnership with VDH to keep this around in the state to support.
All right, thank you. I don't think we do the animal welfare.
You do not, no.
We probably, some of us would like to do that. For kids and puppies. All right,
Madam Chair, if I may
Yes.
interrupt, Noel Langlock of Fiscal Office. This is a list that Amy put together from the public meetings.
yeah,
There were some other requests that were made to the committee directly, that were not necessarily a public meeting. I'm taking an example, Healthcare Advocate had asked what they did, House Healthcare, some of that stuff may not show up as public meeting line. So there were other asks.
Yeah.
Like, this is just specific to the public meeting.
okay. And I know, Mike Fisher has brought some requests, and if you could bring that written copy into us again, that would be helpful. Good. So
What's our timeline on all this?
here's my.
Did you get more days, Jenny?
Yeah, so here's what we're
Round
doing.
and flesh per day.
No flies. That brings back to mind, the quality of mercy. Okay, now. We know that speech. So we do have some time. What I'm gonna suggest to the committee is you look at this list. It is online. You can link in with joint fiscal's webpage and kind of figure out what each one of these requests was when it came in. I know FQHCs are here and they've had that request going on. We have heard about that for a while in terms of your perspective on maintaining link with the federal requirement. Then there's a difference of opinion there. We understand that too. We understand also that there might be other requests, so. My request of the committee is to look at this with an eye for, number one, we're not interested in starting brand new programs through, that would be ongoing, but we do want to be looking at those things that might have been funded previously or that are supporting our most vulnerable populations. And I will try to get back to this again tomorrow, find a little piece of time for tomorrow, but very definitely on Friday, we'll try to make a list as a committee. I know how hard that's gonna be, but we'll make a list of those things. If you can do that for tomorrow, start thinking about those things that you would prioritize here, if there's any money left over, because there's no money. But if there's money, or things are gonna be restructured, these are the things that our committee would recommend, funding. So let's look at it. We'll take a little time tomorrow, and then we'll try and structure some more structured time on Friday to put together a list. I'm not thinking about a big memo this time, but list something.
How do the bills that we haven't really dug into yet, but that have appropriations in them, how do they fit into this puzzle?
Well, we've passed them out, which demonstrates our support for those bills.
We haven't, yeah, I mean, there are a bunch of House bills that we
No,
haven't yet.
Oh, yeah, no, well, those bills will leave, we prioritize them by sending them out, and most of the bills that we'll look at that have come from the House are already in the budget. So what we will do is we will look at those bills in terms of, will they make it through the process? what can we do to ensure that they'll make it through the process? Pass them out, they will go to appropriations. I think in particular 721, the Medicaid bill, which is got a very large appropriation in it, and I know it's already been, people are looking at it big time. So we'll be talking about that bill and passing out our recommendation. When it goes down the hall, then it will be considered there again. I do know that there's interest in having, for me, at least, you know, we have to have some of that bill has to go forward. There's a lot of good stuff in there that is fully supported. It is a very high cost bill. Understand that. The Medicare savings program is huge, and I think that's a lot of support. If you're gonna prioritize what's in the bill, that one might come out as a top. So those are the kinds of discussions that we have in here on each of our bills. And then we continue to advocate for support and they get to,
Well, I guess I just don't wanna get to the point where we're saying yes to some of these when there are things that I would rank much higher that are in those bills.
oh, well, this is what we can,
Supporting pregnant women who are Medicaid, just above the Medicaid eligibility line, supporting technical analysis to make sure we can move forward with the Medicaid expansion. I think those would rank higher for me than most of the things on this list, and I wanna make sure that we're looking at it in that
and so
context.
when we talk on Friday and set up our list, we can do that. We can say that the following bills that we are working on or passing out are our highest priority. We can do that.
Okay,
So, so that would move us more in a direction of having some kind of memo, as we've had in the past, and I'm happy to do that, as long as I can get Ledge Council to help us, structure that.
and we do have time.
Didn't have Friday,
Just,
that's what we have.
You have Friday.
Friday. There we go.
This is ridiculous. I mean,
Well, that's another discussion, Senator, but we've known we've got crunches going on, so we've had so many bills come to us from the House with a lot of money that, not only is the money in the bill, but the way the money is raised is in the bill, and it has moved us away from the usual appropriations process where all the money is put in the big bill, and then finance looks at how to raise the money along with ways and means. So it is it's a different way of looking at this, and we're being held hostage to that new process.
I don't think that's true. I think that the House was trying to
Solve some problems.
solve a lot of problems, and they were doing it in creative ways, and they were doing it with limited time, and I appreciate their efforts,
Oh.
and it's not holding us hostage. We should be more flexible in the Senate and allow the time that we need to consider these really important bills.
So yesterday in caucus, we heard what the timeline is. If you back up from May to right now, that's the pressure we're under. That's just the time is what it's.
And our morning committees are always on before that, right?
April
Yeah. And
So we'll wrap that discussion and we'll come back to a little bit of it tomorrow, but a lot of it more on Friday. And Amy, where did she go? She's at. Oh, we go through it. Thank you, Amy.
It's a process, but so the April 29 morning committee,
We're shut down.
yeah, so, I just wanted to send a logic of that.
Can we do this, please? I would like to move on with the agenda. And I know that everyone has a lot that we want to talk about, and I'm not you, all of us, we want to talk about a lot of different things. Well, at the end of the meeting, we'll take some time to talk through the process, so that'll help you answer those questions. So no one, thank you, and thank Amy again. So, we are on H 721, which is the bill that Senator Hardy was just referring to and that I was referring to. And we did get a walkthrough, but Nolan, you've got the fiscal note, put the fiscal note up and look at it. I'll give you that.
Oh, I'm not even zooming in, sorry. Should have done that earlier. For the record, Noel Langwell, fiscal office, as I get in here, so I'm gonna focus on the spending on the bill and not on the revenue in the bill.
Okay.
Initially, we had scheduled the rest of the team to come in, but after a conversation with the chair, we felt it might be, for time's sake, since that, all that revenue stuff is gonna be in finance anyway.
It doesn't mean we can't,
Yeah.
alluded to.
I just asked that we spare their
Yeah.
busy schedule. So I'm only gonna focus on spending cards, the Medicaid and study and Medicare saving program, and I cannot answer the revenue questions.
Okay.
If you do have revenue questions, we can have those folks come back in, but I think time's sake, and the schedule just made more sense. So, you have the fiscal note. There are three pieces in this bill. There is the expansion of the Dr. Dinosaur program.
Can I ask a question?
Sure.
Does the committee want to have the fiscal note in hard copy? For this bill?
Sure.
It'd be great. Yes.
I don't have it somewhere, but-
Can you do that too? We'll get it from them.
This fiscal note is kind of like a book. It's 5 pages long. And then I add an appendix on the back with definitions of the various Medicare savings program terminologies, Medicare Part A, Part B, QuimB, SlimB, QI1, VFARM. These are things that are very weedy. And I do recommend that if you have questions or want to know deeper about QuimB, SlimB, QI1, that you would bring in either both Diva or Mike Fisher, but I am not the person to explain QuimB, SlimB, QI1.
Got it.
So, with that sort of deferring of responsibilities, the three major pieces that spend in this program are the expansion of Dr. Dinosaur, there's a technical analysis, and then there's the Medicare savings program. So the Dr. Dinosaur program would include young adults ages 19 and 20, and pregnant individuals up to 312% of the federal poverty level. And I have a little chart on there what 312% is.
So it expands from 138% to 312%.
Yes. This would be effective January 1, 2026, so it's a little bit out, and that's because it allows time for technical analysis, which I'll talk about in a minute, and other pieces. And also just rollout time, staff up, et cetera. So the estimated fiscal year 26 cost expansion is 8.18 million, 3.45 million in general fund because of the national commitment. Annualized these, and again, it's a half year if it starts in January, so that's only a half year cost in 26. So annualized, it would cost $16.3 million or almost $7 million in general fund. The bill would also appropriate $1.2 million, 360,000 of which the general fund to DEVA in fiscal year 25 for the implementation costs associated with the expansion. So it's as a January 1, 26 start date because DEVA said that's how much time it would take us, I think, to get this program up and running. Bill would also appropriate $450,000, $250,000 of which for general fund in fiscal year 25 to AHS to undertake a technical analysis. And I won't go over the weeds of what's in the technical analysis because that's in the bill, and I believe Jen have already walked you through that. And then the bill would expand the income limits within the Medicare savings program and repeal the VFARM program because a lot of those folks would be moving into this new program. It had to be approved by CMS, the Center for Medicare and Medicaid Services. And once fully implemented, it would have an estimated annual cost of $43 million, but $15 million of which would be general fund. So there's a very big federal match in this particular program. Implementation could start as early as January 1, 2026. But this would depend on the timing of both the CMS approval and the phasing out of the VFARM program, because there's also, as you phase out the VFARM program, there's savings that would happen, so there could be some duplications in the short run. People who are eligible currently on V Farm are now in a new program, there's some rolling out in that piece. The bill is appropriated, the bill is, the bill would also appropriate $200,000, $100,000 of general fund to DEVA in 25 for the administrative costs associated with implementing this program. And I already said this, the earliest this program would be able to start would be January 2026, and that would be a 26 budget appropriation. And finally, although that's a revenue thing, the HIT fund. So that's a revenue thing. And then if you look at the last, I have lots of charts in this. 312%, you know what that is. I try to show the breakout of the spending for the young adults 19 and 20 and pregnant individuals, so you can see what the cost breakouts are over time and the implementation costs as well. I do have some information about NB Slim being Q1 for informational purposes, and then what the current income limits are and what the costs would be to those folks. And then finally, on the last page, page 4, I should say. And again, I'm skipping all the revenue stuff. I have a breakdown, a summary of the costs over time.
Okay, well, I was gonna say, we could just look briefly at each of the sections. Senator Weeks has a question.
While we're at a summary level, so I thought part of the bill was to, the effect of, taking folks who are on Medicaid, up to age 26 if their parents were on Medicaid. That's not part of this bill?
No, currently folks, you probably know this, but under the Affordable Care Act, under private insurance, people can cover their kids up to 26. But this bill only goes 19 to 20, and now to a certain limit.
Okay, and then the second question is, what is the Medicare savings program?
Going back,
So Medicare saving, I'll do a very high level, but again, as I said earlier, I would defer to DEVA to get into the specifics, or Mike Fisher, either or, but basically.
yeah, we're
Medicare
gonna
savings
have
program-
Diva come in and they're gonna show us different levels of.
So the whole appendix A is about.
Well, if you go under the appendix, it's all about the different pieces, explaining it. But if you go to page 2, there's a short definition. The Medicare savings program helps reduce out-of-pocket Medicare costs for low-income individuals. So even though it's Medicare, it's a Medicaid program to help people pay their Medicare drug costs. Yes. It's complicated, which is why I'm deferring.
I'm trying not to
responsibility
remember when we said that.
Because essentially right now, people on Medicaid, people with low incomes who are on Medicaid, there are no or very few cost sharing. But once you get onto Medicare, there are. So there's a cliff. People suddenly, once they qualify for Medicare, have this big cliff where they have a lot of expenses. The Medicare savings plan helps them pay for those.
It's interesting, because I just read another article about this and how the comments are that everybody thinks Medicare is just wonderful.
Yeah.
The reality is.
It should be Medicaid for all, not Medicare for all. It's a better program. And the original bill as introduced would have taken Medicaid eligibility or Dr. Dinosaur eligibility, which is the children's Medicaid program, up to age 26 to match it with that federal cutoff that Nolan mentioned. But the House did it only to age 21 because that is the age at which the state can do it right now without approval from CMS.
Right.
And it doesn't matter if their parents are on Medicaid or not, it's about them, about their income level.
Right. So, and we'll hear from Diva on all of this, and Mike, we'll hear from you as well. And Nolan, did you want to talk through any more of the fiscal that we're on you at this time? And so since Mike, you're here, do you want to make a few comments? Yeah, that would be helpful.
Good morning.
Morning.
Mike Fisher.
So just a few minutes on your thinking on the bill, where it is, and maybe you've heard some of the questions regarding programs and from your position, maybe.
So, first off, the HCA is in support of that House version of H 721. We have a number of things in it that I think are important. And I will start, and I guess fair disclosure, the HCA has been working for a number of years on the Medicare Savings Program eligibility project. And so this is sort of the culmination of many years of work.
And the working group that we have.
And yeah, and
Working hard on this.
many states are recognizing the opportunities to expand Medicaid programs for people who are on Medicare. And keep saying that, it is confusing. But I'll start at the other end for just a second. The expansion of Dr. Dinosaur for 19 and 20-year-olds, I think is a good thing. And if you want to spend a minute on it at some point, there are some losers, potential losers, but there are far more potential winners. And so we think that's a good step forward. The expansion of Dr. Dinosaur pregnancy from 211% to 218%. I apologize, I used the Magi numbers are what's in my head, not the statutory, so I'm off by 5. It's also just anything we can do to improve access to prenatal care delivers in spades back. It's just the right thing to do. And so fully in supporting of that. And then the analysis that's included, there's a number of pieces of analysis in the bill that I think are also important. Yes, an analysis of further expansions of Medicaid, how we could do it and pros and cons of it. But also there is an analysis of what opportunities we have if the enhanced premium tax credits are eliminated at the end of this coming, I think, 25. It's a big deal. And it will require that.
Can you briefly explain what enhanced premium tax credits are?
Yes. So originally in the ARPA bill and then extended are an enhancement of the premium tax credits for people in the individual market that not only raised the level of support for people at all levels, but eliminated the 400% of the federal poverty cliff. Previous to that, there were dynamics where family, and sort of the worst of it, a family at $1 over 400% of the federal poverty level would lose as much as $11,000 in tax bills. It was a back that currently is not existing because the enhanced premium tax credits shifted to a percent of income benchmarked against the second most cost of living, a percent of income that goes all the way up, 8.5%.
And it's gonna go away unless there's an act of Congress.
It is currently funded through 2025. And it's required an act of Congress, and I will leave you to.
Any act of Congress we can go.
And an act of Congress, particularly on healthcare access. So we are very concerned about that, and when the ARPA subsidy started, and I'm speaking about this more than anything else, but when the ARPA subsidy started, the HCA came to the legislature with the question, given the significant protection for the individual market, did it make sense to separate the individual and small groups? And with that conversation, we all landed on it that it made sense. That decision saved the small group $17 million real relief in that year. With the elimination, if the enhanced tax credits are eliminated, the small group is exposed again. We put the individual and small group together in 2011 because the individual group was in serious trouble. Familiar with the phrase, as costs go up, healthier people leave markets, leaving only sick people in markets, and costs go up. And that is a spiral that is devastating for small markets.
So the small market's not in this bill.
So, but the study of what to
Study of
do
what
about
to
that.
do is in the bill.
Sorry, thank you for.
Yeah, I
bringing
want to
that.
bring it back to the bill because I needed to see that Jen is in the room and there
Yeah.
might be questions that she might
So-
want to answer.
So if I can just say on a very high level, and I'd love to tell you much more. The Affordable Care Act and our health policy work for years in the state, in this country, have focused on people who are under 65 and non-disabled. We have substantially left behind older and disabled Americans, Vermonters and Americans. With the exception of Part D and B Farm, there was some prescription drug stuff that happened at the federal and state level. But largely, we had to with them. And so there is the Medicaid funded program called Medicare Savings Plan, sort of seeks to fill that space. A number of our neighbors, including New York, Massachusetts, and Maine, Connecticut, I understand Rhode Island is doing it this year, and a couple other states have stepped into this space of improving access to these supports so that these very low income, older Vermonters are not left behind.
And that is in the bill as it passed.
That is in the bill, and it's.
We'll look at that, and I know that there are different levels, possible levels, but we don't want cliffs.
And maybe I could just, as a teaser, say, I do support the House passed version. I think there is some improvement that could be done to it. That would not cost more, in fact, would cost less. And I think that there were a number of models explored in the House, and I think they could be improved. We've learned a lot in this process, and there's some complicated math in the back end that we now understand how to work better. The New York model, and so we think there's some improvements to those.
I've asked Steve to come in to share with us that information. Thank you. So we're looking at 721.
I don't think we've ever known. I don't know.
I know.
Oh.
We have a few minutes until Michelle gets here. So maybe the high level, if you have time.
I said you had it, so they'll generate my this, I guess.
Enthusiasm. We do have testimony from the mayor of Burlington. I'm just looking at it quickly before we go ahead. Is she on Zoom yet? She's not on yet, so we'll let her know that we're gonna be a few minutes behind, but we do want to hear her comments on 7.2.
So do you want me to put it up or do you have it in front of you?
Maybe put it up.
Yes.
And Jamie, we're a little bit behind, so I've just had Kiki let the mayor know, and we'll be picking that up in about 10. Okay. So the bill is about increasing access overall and for people saving access and affordability, actually.
Good morning, Jen Carmen from Dallas Legislative Council. So this is H 721. I think you had an overview from the reporter from the House, but I don't think we ever did a lot.
We never finished the full book.
So it starts out with a short title, Medicaid Expansion Act of 2024. There are a number of findings.
Yep, we can see.
Yeah, about Medicaid, Dr. Dinosaur, uninsured, underinsured. I think we'll 65 and over. All right, then in section 3 requires the Agency of Human Services to expand coverage under the Dr. Dinosaur program to all Vermont residents up to 21 years of age who have income at or below 312% of the federal poverty level, and to pregnant individuals of any age in that same income category. So under existing law, coverage is available up to 312% of the federal poverty level up to age 19. So this would allow 19 and 20-year-olds to come in and put the line at 21. And under existing law, also pregnant individuals up to 208% of the federal poverty level of any age are eligible. This would increase that income threshold to 312%. Premiums are allowed. This does, in Dr. Dinosaur, this does not change that. We get to section 4 is the technical analysis that you've heard a lot about. There's kind of 3 aspects to it. One relating to expanding access to Medicaid and Dr. Dinosaur, one part relating to rates paid to healthcare providers for providing services to people on Medicaid and Dr. Dinosaur, and one to the structure of Vermont's health insurance markets, which is a piece related to one of the things that Healthcare Advocate was talking to you about. So it goes into detail on each of these, but it's looking not just at what it would look like to expand, but whether we need waivers, federal waivers, whether we, what it would look like timing wise and cost wise, both to implement and the ongoing programmatic costs. So for expanding eligibility for Medicaid to those 300 at or below 312% of the federal poverty level, expanding the eligibility for Dr. Dinosaur. So the bill does it up to age 21. This would look at doing it up to age 26, which is the same age at which kids can stay on their parents' private health insurance under the CARE Act. Expanding eligibility for the immigrant health insurance plan, the Dr. Dinosaur-like coverage that was created a few years ago. Sliding scale cost sharing. Then we have provider rates, and there's lots of aspects to that. I don't know if you want to dive into those or just say there's lots of looking at different ways that we might benchmark it to other types of payers, how other states do things, different percentages of Medicare. And then there's a definition of provider type. Some of this is looking at it by provider type, and it's listing a bunch of different types of providers that Medicaid has different fee schedules for. And looking at different aspects of the health insurance markets, whether to make any changes to the existing structure, other ways to address the upcoming expiration of the enhanced premium tax credits under federal law, and a public option. So most of this technical analysis would come back next January 15th. But there are 2 pieces related to Medicaid rates and commercial health insurance that Diva needed longer to dive into. So that would be January 15th of 2026. Section 5 has some additional information being provided annually about the global commitment investments. These are the things the state is able to get federal Medicaid match on that otherwise would not be eligible for federal match absent our global commitment demonstration. And so a list is currently required to be submitted. That would continue, but it would also require more detailed information from AHS annually as part of its budget presentation about each of the investments, who's served, what it costs, how effective it is, who's responsible in state government for managing it. Section 6 adds a new annual report relating to services that the Department of Vermont Health Access has considered for new, modified, expanded, or reduced coverage under Medicaid, including why they looked at it, what they considered, and why they made the decision they made. This is in addition to the Clinical Utilization Review Board, which is a little bit narrower scope. Section 7 is the Medicare savings programs that Mike Fisher was just talking about, and this would increase the income thresholds for the qualified Medicare beneficiary program. Quimby specified low income Medicare beneficiary SLIMB and qualifying individual QI programs to significantly higher income thresholds than they currently apply. And I don't know the details that he went over with you, but there's different benefits in each of those programs that help people afford their Medicare costs. Section 8 directs the Agency of Human Services to request approval from CMS to amend our state plan to do that expanded eligibility for the Medicare savings programs and seek any other amendments or waivers we need. Section 9 would repeal the V-Farm program on the later of January 1st, 27 or 12 months after CMS approval, because these newly expanded programs would make that largely unnecessary. Sections 10 and 11 extend the health information technology portion of the claims tax for an additional year. 2 years, it would otherwise sunset in 2025. This would extend it to 2027. We have the appropriations that I assume were most of what Nolan went over with you. So some global commitment funding and the mechanics necessary for that. 1.2 million to implement the Dr. Dinosaur eligibility expansion to age 21. 450,000 in global commitment funds for the technical analysis, and 200,000 for the Medicare savings program eligibility expansion implementation. And state's intent to use a portion of the revenues generated from what hopefully was also already gone over with you.
We actually did not, but it's pretty clear on the
Tax
fiscal
stuff.
note where it's coming from and that
Lots of tax stuff I can't explain, but we can have
Right.
Kirby in if you want to get into the details. And when we do the dates.
it's like $39 million in taxes that could be generated.
And that, right, the use is split between this bill and the judiciary public safety bill.
And this is in the budget from the House.
Take into consideration.
Yeah.
Okay.
Okay.
All right.
That's it. We thank you. We'll come back to this,
Yeah.
obviously.
I need something else, so at least now you have the framework.
Good. Great. So, now we've been working on H72 and based on testimony that we heard the other day, and we're gonna hear more testimony today. They'll be able to look at perhaps a new, the latest draft and move along. So I think that Mayor Emma Mulvaney Stanek is here on Zoom with us to talk about H72.
She will be sure.
She will be short. Okay. And I'm gonna try and take a break. As close to 11 as we can get it, and then come back to do more on 233 to PM.
Okay. If we're waiting for Anna, should we take a break?
Because she's there.
Oh, she, oh, I thought,
She's zooming in.
oh, I thought he said she went there, yeah, okay.
She's back, right?
She's net to June.
Back she is.
Yeah. That's the her assistant. I've just emailed her assistant.
She's not there, so can we take a break now while we wait for her?
Fast. You only have 1 minute. It's not a real break. You need to stand up.
Seems to get a 5.
Jamie, do you know if she's on her way? Did you text her?
Texted, yeah, should be getting out of the department head meeting.
But she was available at 10.
Yep, she did.
Well, she can wait. Huh? That's not.
Do you have